this. Okay. Okay, well, welcome everyone to today's paediatric teaching. Today it looks like just looking at the people who've come online, we've got people from Mount Hagen and from Wewak, from Madang, from Port Moresby, from Alatau, and we welcome friends from Yogyakarta in Indonesia as well. This is a series of lectures that happen every week, and it's part of the postgraduate pediatric teaching program in Papua New Guinea, and it's we go through a curriculum, so there's there are varied topics we talk about each week. It's designed for our postgraduate diploma and master's candidates, and nurses also come along, and as I say, we welcome our colleagues from Indonesia as well. So today I wanted to talk about antibiotics and antibiotic resistance, and I know many of you are experts in this area too. The use of antibiotics is a big part of pediatrics, isn't it? And we have to be experts in about antibiotics, but also about antibiotic resistance. And I'm going to be talking about some simple concepts and some more complicated concepts, I suppose, so that you can get an understanding of antibiotics and antibiotic resistance. So this is what we'll talk about today in this hour. So I'm going to describe some steps in antibiotic prescribing, some general principles that you really need to remember. So I'll just have to admit a few people in. Some general principles that we should all remember whenever we're prescribing antibiotics. I will describe how antibiotics work, because that helps us understand how resistance can occur. I'll explain why resistance occurs, and then I'll talk briefly about a couple of specific types of resistance that are a big problem. So one's called ESBL, or extended spectrum beta-lactamase, and the other one is MRSA, which you know is methicillin resistant Staph aureus, of course. And then I'll talk about another type of resistance just briefly, which is even more resistant organisms, which are called carbapenemase resistant gram-negatives. And throughout Asia, many parts of Asia, carbapenemase resistant gram-negatives are growing. So this is important that we understand about antibiotics and how they work and how resistance occurs, because increasingly antibiotics, bacteria are becoming resistant to the standard antibiotics that we were able to use 25 years ago. And then I'll talk a bit about antibiotic stewardship, which all hospitals really should have a program of antibiotic stewardship. And if your hospital doesn't have one, then encourage it to start, and even start one in your own pediatric department. It's very important to have such a program. So I just wanted to talk a bit about the steps in antibiotic prescribing, because sometimes we just assume that every child who comes with an infection needs an antibiotic, and we look up the book and we give the antibiotic. But the first question always to ask is an antibiotic needed? And that's based on the idea that the question, is the child likely to have a bacterial infection? So many of the infections we see, at least half of them are not bacterial. And for many children, they don't actually need an antibiotic. So we've got to decide, do they need an antibiotic or don't they need an antibiotic? That's the first step. Secondly, we need to have some evidence for using antibiotics. So if you can in your hospitals, then take cultures before giving antibiotics. And that might be a blood culture, a urine culture, a lumbar puncture for CSF, you know, the sorts of cultures I'm talking about, or it might be in a post-operative surgical case, then ensuring the right swabs are taken from the right locations where there may be a wound infection or something like that. So take cultures if you can, and that can really help in the coming days. You should choose a standard antibiotic for that infection. So we have standard treatment from the standard treatment manual, and the World Health Organization has standard treatment for various infections. So you should always choose a standard treatment, or start with a standard treatment, but then you should assess the likelihood that child could have an antibiotic resistance, that child could have an antibiotic resistant infection. And sometimes you can get a good idea of that by the risk factors for antibiotic resistance, which we'll talk about. You should choose a drug that has adequate tissue penetration. So mostly standard treatment gives us the right antibiotic to choose, but sometimes for some infections, we need to be clear that the antibiotic is going to get to the tissue where there's an infection. So that's something, I'll talk a bit about that in a moment. And then you should also consider other things like the kidney function of the child or the liver function. And sometimes that influences the choice of antibiotics we have. So if a child's got substantial renal impairment, then we would avoid using aminoglycosides. If a child's got substantial hepatic liver impairment, then we'd avoid cloxacillin or flucloxacillin if we can avoid it, and we'd probably avoid ceftriaxone too, because they can cause an exacerbation of liver dysfunction. So we should aim for a single drug with a desired spectrum of activity. So I see a lot of children that have infections and maybe on 3 or 4 antibiotics, and sometimes that's necessary, but mostly it's not. Mostly it's not. It's better to use a single drug with a desired spectrum of activity for the bacteria that you think are causing the infection that you know is there, right? We should ensure that sometimes 2 antibiotics are useful, but typically it's very rare that you need more than 2, and you should narrow the spectrum down if you can. We should ensure the correct dose and the correct route of administration. That's obvious, but I do see children who are treated with either the wrong dose, either too low or too high, and it might be too high because of their characteristics. Like for example, if they've got renal impairment, kidney failure, then using a too high dose of antibiotic can make it worse. And we should ensure the right route of administration. So if you've got a child who's got a very severe infection, clearly they are more likely to need a parenteral antibiotic, intravenous antibiotics. But if you've got also, on the other hand, if you've got a child who's got a moderate infection, a moderate bacterial infection, then often the oral route is just as good as intravenous. And so not every child needs intravenous antibiotics, but some children do. So we should choose the most appropriate route of administration based on how sick the child is. We should start an antibiotic without delay in a severe infection. It's sort of obvious, but I do know of many children who've had antibiotics delayed by several hours when they have a critical infection, and that can lead to severe outcomes. So we should start early without delay after you've taken cultures. This is something very important, that we should ensure early and adequate source control. So we've all seen children who are treated with antibiotics, but the antibiotics don't work. And that's because there's not adequate source control. They had an abscess that wasn't drained. They had a collection of pus that wasn't drained, or osteomyelitis that needed surgery. So the point is, unless you've got adequate source control, the antibiotics won't work. So we should always strive for identifying the source of the infection and ensuring that you've got adequate source control. If you've got a collection of pus somewhere, then you haven't got adequate source control and the antibiotics are unlikely to work. Now, I said you should start antibiotics without delay, but you also need to have some stopping rules. All right, and this is an important concept that probably up until now we haven't really had. We've sort of started antibiotics and assumed that they should be used for the next 7 days or the next 10 days, whatever the standard treatment says. But it's also useful to have stopping rules, and I'll try to explain what they are. We don't always have to go for 10 or 14 days with antibiotics, and often that can lead to major problems, either complications from the antibiotics themselves, antibiotic-associated diarrhea, or it can increase the risk of resistance. When we think about antibiotics, we always look to standard treatment for the right antibiotic to use, and that's appropriate. But we also should have an idea of what antibiotics work on what bacteria. And so I've just got a list here of when we think about bacteria, we should think about the gram-positives and the gram-negatives. Right? And so for most clinical infections, we can say it's more likely that this would be due to a gram-negative or more likely this would be due to a gram-positive. So, for example, if a child's got a urinary tract infection, then it's more likely that I'll just admit some people, if a child's got a urinary tract infection, that's more likely to be due to a gram-negative bacteria. If a child's got cellulitis, it's more likely that's due to a gram-positive bacteria. So we can get a fair idea of what the likely bacteria are from the clinical infection the child has. If a child's got pneumonia, then it's likely that's due to a gram-positive infection, pneumococcus, sometimes a gram-negative infection like Haemophilus, right? If a child's got is severely malnourished and has severe sepsis, then they might have either a gram-positive or a gram-negative infection. So some children could have either. So the sorts of antibiotics that will treat gram-positive infections, depending on the type of infection, the penicillins, so they are a class of drugs, penicillin, amoxicillin, flucloxacillin, they're all penicillin-like drugs. And then more advanced than that are the third generation cephalosporins like ceftriaxone and cefotaxime. Macrolides are like erythromycin or azithromycin, and that they treat atypical organisms typically, but they also treat gram-positive infections. And then there's cotrimoxazole that treats both gram-positive and gram-negative infections. And then ciprofloxacin, it will treat both gram-positives and gram-negative infections. And then there are antibiotics called glycopeptides, so vancomycin and linezolid, which we've been using a bit for resistant TB, but it's also useful for staph and for MRSA, like vancomycin. So these are the antibiotics that will treat gram-positive infections. And if we can identify a gram-positive infection, we need to use the right antibiotic for that. Gram-negative infections are a bit fewer antibiotics, but aminoglycosides, of course, gentamicin, tobramycin, amikacin, they're all very good treatment for gram-negative infections. Aminoglycosides also do have some cover for some gram-positive infections, but mostly it's gram-negative infections. Ceftriaxone and cefotaxime, they have cover for gram-negative infections as well as gram-positive infections. And then going up the scale, the sophistication of antibiotics, meropenem, they're carbapenems, and they treat both gram-positive and gram-negative infections, but they should only be reserved for highly resistant infections and not used for most infections. And then, as I said, ciprofloxacin is an antibiotic that has a specific indication, a very important indication for an infection I'll talk about a bit later. And then cotrimoxazole, which treats both gram-positive and gram-negative infections. But again, that has a very specific indication for a couple of infections like pneumocystis, pneumonia, and other infections. I wanted to describe how antibiotics work. And when you think about a bacteria, bacteria are fairly simple organisms. They have a cell membrane. Some of them have a thick cell wall. They make protein through the normal process of protein synthesis with DNA and RNA and ribosomes. And so they need a certain number of molecular mechanisms to make protein. That's really all they are. They make proteins and they have a cell wall. And antibiotics work in a number of different ways. And so sometimes it can be in inhibition of cell wall synthesis. So antibiotics may kill bacteria, or they may stop them multiplying and stop them regenerating or repairing themselves. So the sorts of antibiotics that cause inhibition of cell wall synthesis, the penicillins, the cephalosporins, the carbapenems, those types of antibiotics, and they inhibit cell wall repair, and they cause holes in the cell wall and lead to cell wall destruction. And so those antibiotics are what we call bactericidal. That is, they destroy the cell wall of a bacteria, and that leads to killing of the bacteria. There are so that's cell wall active antibiotics. There are other antibiotics that disrupt the cell membrane. And so there's a few that disrupt the cell membrane. They're a bit like cell wall antibiotics. So polymyxin is one of them. It's quite a good antibiotic for staph infections as well. And they disrupt the phospholipid bilayer of the bacterial cell wall membrane. And then there's some antibiotics that just inhibit protein synthesis within the bacteria. And so erythromycin and chloramphenicol, aminoglycosides, and tetracycline, they inhibit the RNA conversion of DNA to protein. And so when you think about those antibiotics, they're active within the cell. They're not active on the cell membrane or the cell wall. And then there's some antibiotics that inhibit folic acid synthesis. So to make proteins in the ribosomal structure and from DNA, you need a certain number of metabolites, and some of those are thiamine and folic acid. And some antibiotics, or particularly cotrimoxazole, inhibits folic acid synthesis. So if you think about it, antibiotics are either destroying the cell wall, putting holes in the cell wall or the cell membrane, or disrupting protein synthesis within the bacteria, which enables the bacteria to multiply, or they're inhibiting other metabolites that are required for protein synthesis. So it's relatively simple in terms of the way antibiotics work, but different antibiotics work in different ways. They all work on, obviously, on bacteria and not on viruses. It's important for us to understand why resistance occurs, and it's a bit like with COVID, how resistant variants pop up anywhere, and there are random genetic mutations that lead to a bacteria becoming resistant. And usually there might be in a particular infection, there might be 1 million bacteria, and there might be only one that has a random genetic variation. But that one bacteria, or a small cluster of bacteria, can then evade the antibiotics. So the antibiotics don't work because that bacteria has a genetic variation that leads to resistance. So to start with, they might not be causing an infection, that small number of bacteria. They might just be bystanders, whereas most of the bacteria don't have that genetic variation. But because the infection is exposed to antibiotics, then the antibiotics will kill all the other bacteria that don't have that rare genetic variation. And those with the genetic variation then survive, and then they multiply and they become a resistant clone that causes a resistant infection. So the more prolonged the antibiotic exposure, the more likely it leads to selection pressure for certain bacteria. All right? This is important to understand. So when people develop, or when resistance develops, it develops in a small way to start with, and then grows and grows, and then it can spread to other patients. So the duration of exposure of antibiotics is very important. And if we can limit the duration of exposure to antibiotics, then we can reduce the risk of infection, of infections becoming resistant. The mechanism of antibiotic resistance, I won't go through this in too much detail, but remember what the mechanisms of how antibiotics work. They can disrupt the cell wall or the cell membrane. They can disrupt protein synthesis, or they can disrupt metabolites that are required for proteins to be made by the antibiotics. And the mechanisms of antibiotic resistance are usually the same, similar to those mechanisms of the way antibiotics work. So some resistance can occur by the disruption of pumps within the cell membrane and the cell wall. You know, cell walls and cell membranes have pumps that pump in and out various electrolytes and allow proteins into the cells. But the resistant clones can disrupt efflux pumps, and they can stop antibiotics actually getting within the cell, so they can't any longer disrupt protein synthesis. They can sometimes disrupt the uptake of antibiotics, so they can change membrane stability. So all the antibiotics that need to get within a cell can develop resistance if they can't get into cells. They can also inactivate enzymes. So one of the major mechanisms by which resistance occurs is by developing enzymes that inactivate antibiotics. So beta-lactamase, which is a very common enzyme that some antibiotics have, can disrupt the penicillins and cloxacillin, all the penicillin-like drugs, because of just a random variation causing a disruption of a random variation causing disruption of common antibiotics by enzymes that are produced by the bacteria. So I won't go through this in much detail, but I think it's just important for us to understand how antibiotics work and the types of resistance that can work. And I'm going to talk about just a few types of resistance that are very common these days, and among bacteria, which we see commonly. And the first one is, as I mentioned, this enzyme called beta-lactamase, which is produced by some bacteria, usually gram-positive bacteria, and some gram-negative bacteria. They're enzymes that can hydrolyze or break down. They can break down the beta-lactam ring of penicillins. Now, penicillins their chemical structure is what's called a beta-lactam ring. Both penicillins, amoxicillin, flucloxacillin, cephalosporins, they all have a beta-lactam ring, and they can be broken down by, it's just a chemical structure, they can be broken down by beta-lactamases, and that inactivates the antibiotic and doesn't allow it to disrupt the cell wall as these antibiotics normally do. The beta-lactamases, so in the past, penicillin, just straight penicillin, used to be adequate treatment for staph infections, and it used to be adequate treatment for some gram-negative infections. But these days, we wouldn't think about using penicillin to treat osteomyelitis or using it to treat a serious gram-negative infection. But back in the 1940s, when penicillin was first identified, it could treat those infections, but especially osteomyelitis, but now it can't, of course, because of beta-lactamase production by Staph aureus. And there are many different beta-lactamases that have developed in that time, in the last 60 years, and including the penicillinases. They were the first ones to develop, and then the cephalosporinases. They're all beta-lactamases. And then late in the last 15 or 20 years, enzymes called carbapentamases, which can occur in gram-negative infections. Initially, it used to be possible to use a higher level penicillin-like drug to overcome these resistance. So when penicillin failed to treat many bacteria, we went to using amoxicillin or ampicillin, and then flucloxacillin, and then we started using cephalosporins, the ceftriaxone, cefotaxime, ceftazidime. Those antibiotics were used when beta-lactamases were at a moderate level in the 1980s. And now those organisms have become even more resistant, so we need other antibiotics that can use, such as sometimes augmentin, so that is stable against beta-lactamase, so piperacillin tazobactam, or clavulinic acid with amoxicillin. So that those higher level inhibitors of beta-lactamase are now sometimes required for certain infections. As I said, beyond penicillinases and cephalosporinases, we now have extended spectrum beta-lactamase producing bacteria. And this has been a very important change. It's been a concerning change among gram-negative organisms, and most hospitals have problems with extended spectrum beta-lactamase producing gram-negatives. These create resistance to third-generation cephalosporins like ceftriaxone, cefotaxime, ceftazidime, and they sometimes also carry resistance to aminoglycosides. So for these infections, for these not very common, but in most hospitals, there will be some ESBL producing bacteria. Then for those organisms, for infections with those organisms, we need to use carbapenems like meropenem or amikacin, or sometimes tazobactam plus piperacillin tazobactam. So that's why you start to see antibiotics like meropenem being used. But we need to identify which patients might have ESBL producing organisms and which ones don't. And that's why we need surveillance for these organisms. Very important to have surveillance, so we don't overuse these antibiotics. Because of the overuse of antibiotics, we now even have bacteria that are resistant to agents like meropenem, and so that they have what's called carbapentamases. Right? They're like beta-lactamases, but they break down the beta-lactam ring in even antibiotics like meropenem. And for those infections, there are really few options. And so it's very important that we don't overuse antibiotics, and we try to limit their duration of use, so we don't keep encouraging the progression of these infections with more and more resistant organisms. There are a few other bacteria that have their own resistance mechanisms, like Pseudomonas. That's a different mechanism of resistance, and they have what's called metalloproteinases. They're just enzymes, a bit like beta-lactamases, and then MRSA, which is another different type of antibiotic resistance, and that leads to resistance among Staph aureus, particularly for cloxacillin and flucloxacillin. And for those, when a child has MRSA infections, then using vancomycin or clindamycin or rifampicin are necessary. I first started getting interested in antibiotic resistance about 25 years ago, when we noticed that many children, a disproportionate number of children who were dying, had antibiotic resistance. And so over a few years, this is in Goroka, when these organisms started to emerge, antibiotic resistance occurred in just 2% of all admissions, but they caused 25% of all deaths. And so what you'll find in your hospitals is that even though antibiotic resistance isn't very common, as I said, 2% of all admissions, that's quite uncommon, but they cause a disproportionate number of deaths. And so that's why we have to be very vigilant about antibiotic resistance and good antibiotic prescribing. This is the same in all hospitals in all countries. A relatively small number of our patients will have antibiotic resistant infections, but they'll cause a higher proportion of deaths in newborns and in children. When we looked at risk factors for antibiotic resistance, it's quite common across the world. And so prolonged hospital stay and previous exposure to broad spectrum antibiotics and long and repeated exposure to broad spectrum antibiotics are the two key. They're the two most important organisms: long hospital stay and exposure to broad spectrum antibiotics. There's a couple of other risk factors in this, the study I just mentioned, and one was children with severe malnutrition, and part of that is that they stay in hospital for a very long time. But I think also part of that is that we always treat them with antibiotics. It's rare that a child with severe malnutrition doesn't get treated with antibiotics. And also they often have a variety of different bacteria, like enteric gram-negative bacteria, gram-negative bacteria like Klebsiella and Enterobacter and E. coli. And they also have disordered gut flora. So their bowel flora is not normal. And that's partly because of their malnutrition and partly because we give them antibiotics. So when you give antibiotics to a child, you change the bowel, the flora in their gastrointestinal tract. So we all have millions, billions probably of bacteria in our gastrointestinal tract, but we have a balance, a fine balance of gram-positives and gram-negatives and healthy bacteria, hopefully mostly healthy. But when we give children antibiotics, that changes the balance in their gut flora. And if a child receives a lot of antibiotics, especially early in life, then it'll change their gastrointestinal tract flora, and it puts them at risk of getting antibiotic resistance. We also noticed that babies born in villages were more likely to have antibiotic resistance, but I think that probably just reflects that they also were more likely to be colonized with gram-negative organisms. So the main things are prolonged hospital stay and previous treatment with broad-spectrum antibiotics, and also some risk groups like immunosuppressed children, children with severe malnutrition, and children born in the village, so born before arrival at hospital, seem to be put children at great risk of antibiotic resistance. I wanted to just give an example here. This might seem like just a common occurrence, but this was a 12-year-old boy who had a tattoo on his arm done by his friend. So him and his friend did some home tattooing, and then 2 days later he developed a fever and his left arm became very swollen. He had lethargy and difficult breathing. Now, what I want to know is what you can see, perhaps if you look at his arm, you can see a difference between the left side and the right side. What could be going on here? What do you think could be going on? Whenever you see a child who's got a swollen, tender arm with a fever, obviously you think of could it be osteomyelitis or septic arthritis or pyomyositis or cellulitis? And when you think of those infections, then you'll be thinking about gram-positive infections, and particularly Staph aureus. And I use this case because I think it tells us something about whether resistant bacteria are just a product of hospitals and exposure to antibiotics, or whether sometimes they can occur in the community de novo. They can just be in the community. And this is an example of where Staph aureus, or MRSA, methicillin-resistant Staph aureus, can occur in the community. So this boy was treated with flucloxacillin for several days and wasn't getting better. And then we grew MRSA from his blood cultures. And I think that increasingly MRSA is not only a hospital-acquired infection, but also it can come from the community. And that doesn't mean that every staph infection you need to treat as if it's MRSA, but you need to think, when you've got a child with a staph infection, an osteomyelitis or septic arthritis or a pyomyositis, you should think to yourself, if it's likely to be staph, is it sensitive to cloxacillin or flucloxacillin, or is it likely to be resistant? And that's a question you should ask yourself all the time, so that you can change antibiotics when it's appropriate. And so this boy, after a couple of days of flucloxacillin, wasn't getting better, so needed vancomycin to improve because he had MRSA. He also had a complication of staph infection that's quite common, and that is his arm is not just swollen because of the infection, but his arm is swollen because he's got a thrombosis. And I want you to sort of think about that when you see a deep-seated infection, deep-seated by like a deep-seated soft tissue infection involving the muscles or the joints or the bones. You should think, is it also involving the blood vessels? And this boy had a severe thrombosis of his the veins in his arm, a thrombophlebitis, and if you, it's important to recognize that, because it sometimes also needs treatment, not just with antibiotics, but sometimes with agents to thin the blood. And when you see a staph infection in one place, you should think to yourself, where else could it be? And this boy had staph pneumonia, which had come from the home tattoo that he did, and also staphylococcal infection in his arm. So think, where else could it be? It could be in the lungs, it could be in the heart valves, it could be a CNS infection, could be in other bones and joints. But we should always think, if we've got staph in one place, where else could it be? This is a similar case of a child who had, again, a community-acquired infection, and what this is obviously periorbital cellulitis. This boy's got a swollen left eye, a swollen, red, hot, inflamed left eye, and you would say the most likely bacteria are probably staph infection. Sometimes that occurs from a mosquito bite on the eyelid, or it occurs from a scratch or something, or an injury to the eye. And you should think to yourself, it's likely to be staph, and it might respond to flucloxacillin, but we've got to think, could it also be resistant? So if it's not getting better in a couple of days, you should think to yourself, have I got adequate source control, or is it a resistant bacteria? This is very important, because to make the distinction is important. If you've not got adequate source control of the infection, if there's pus somewhere, such as in this boy, if there was pus in the bones, like a sequestrum or some abscess in the muscles, then no matter what the antibiotic you give is, it wouldn't work. So you've got to think to yourself, if it's not getting better, have I got adequate source control, or could the bacteria be resistant, or should we just keep going for a bit longer? Right? So these are important questions you need to ask yourself. So MRSA is methicillin-resistant Staph aureus, and of course we don't use the antibiotic methicillin these days, but the laboratory uses it to detect resistance to flucloxacillin or cloxacillin. And methicillin is the same as flucloxacillin, and that's the same as cloxacillin. They're all equivalent drugs, but clinically we use flucloxacillin or cloxacillin, but the laboratory uses methicillin just to detect MRSA. And MRSA causes the sorts of infections I've mentioned. It causes abscesses or boils or cellulitis or osteomyelitis, or complicated staph infection with lung abscess or empyema, sometimes endocarditis. It's more common in children who have some risk factors. So sometimes children who've got diabetes are more likely to get staph infections or MRSA. And in some communities, MRSA is a bit more common because there's MRSA circulating within the community. It can be hospital or community acquired. This is important because in the past, in years gone by, MRSA was only a hospital bacteria, but it also can be community acquired. Now, again, that doesn't mean that we should treat every staph infection with a very high-powered antibiotic like vancomycin or linezolid, but we should just ask the question to ourselves, is this sensitive or resistant Staph aureus when you see a staph infection? In fact, in Kundiawa, there was a study done of 70 children with osteomyelitis, and 85% of those 70 children, so 40 of the 47, had methicillin-resistant Staph aureus. So this was quite an unusual situation where a lot of osteomyelitis, in Kundiawa at least, were resistant to flucloxacillin or cloxacillin, but they remain sensitive to these antibiotics, to chloramphenicol. Interestingly, chloramphenicol, clindamycin, cotrimoxazole, gentamicin, and a lot of MRSA, methicillin-resistant Staph aureus, remain sensitive to these types of antibiotics. So we do have some other antibiotics that will work in MRSA, but it's important to be asking the question, if a child's got a severe staph infection that's not getting better with our standard antibiotics, with flucloxacillin and gentamicin, then if the child's not getting better, ask the question, could they have antibiotic resistance? Another infection that I want to highlight, so I've talked about soft tissue infections like staph infections, but dysentery is also an infection that over the last 20 years has become increasingly resistant to standard antibiotics. So this is an antibiotic profile of children with dysentery over a 10-year period in a study in PNG. And previously, we used to use amoxicillin or cotrimoxazole for the treatment of dysentery. But you can see there that the proportion, the percentage of sensitive organisms, I'll just move this over here, the percentage of sensitive organisms that are sensitive to amoxicillin or cotrimoxazole is very low, whereas the percentage that are sensitive to ciprofloxacin is very high. And that's why a few years ago, the standard treatment was changed from using amoxicillin or cotrimoxazole for dysentery, changed to using ciprofloxacin. So again, we have to be very careful about the use of ciprofloxacin, and we have to only use it for certain infections like dysentery. Otherwise, the problem will be that the Shigella that causes most of the dysentery will develop resistance to ciprofloxacin, and also preserve the use of ciprofloxacin for MDR-TB, of course. So it just is important, because 25 years ago, we could have used amoxicillin or cotrimoxazole, and that would have been highly effective against most cases of dysentery. But now, of course, it's not usually effective, and we have to use ciprofloxacin. Or if a child is very unwell, of course, we use ceftriaxone. But that's the bacteria Shigella, the Shigella species that causes most of the dysentery in PNG. This is called an antibiogram, and I won't go into this in too much detail, but these are very useful displays of the types of levels of resistance that we see in certain bacteria. And what this shows, this shows the percentage that are susceptible, right? And so for Staph aureus, for example, only 12% of Staph aureus isolates are now sensitive to penicillin and ampicillin. So it's very rare. If you had a child with a staph infection, you wouldn't use ampicillin or penicillin because they're unlikely to be susceptible. You might use chloramphenicol because that's still susceptible. You might use ceftriaxones, half of them are susceptible. Even cloxacillin of the Staph aureus is about half as susceptible. It looks like here that more are susceptible to gentamicin, but gentamicin alone is not a very good treatment for Staph aureus. So that's why we still use flucloxacillin and gentamicin together. Together, they are usually effective. And if you've got an organism that's resistant to cloxacillin, then you need to use vancomycin or another drug, clindamycin or rifampicin or linezolid. And similarly for Klebsiella, that's a gram-negative that's become highly resistant, hasn't it? So this is the susceptibility pattern in the antibiogram for Klebsiella, and all of them are shaded red because none of these antibiotics are highly effective these days for many isolates of Klebsiella. And for many isolates of Klebsiella, we have to use a high level antibiotic. It's good to know that for the common causes of common infections like pneumonia, still 90% are susceptible to penicillin and ampicillin. So if we've got a child who's got staph pneumococcal pneumonia due to Streptococcus pneumoniae, then it's likely that they'll still respond well to amoxicillin or respond well to ceftriaxone or to chloramphenicol. The reason why we've gone away from using chloramphenicol for serious infections is partly because of the rising resistance among Haemophilus, and especially for meningitis. As you know, more than 80 or 90% of all Haemophilus now are resistant to chloramphenicol. So we'd never use chloramphenicol these days for the treatment of bacterial meningitis. It's still effective for some infections, however. For pneumonia, it can be effective, although it has some dangers. And for some staph infections, it has some effectiveness as well. I mentioned at the start, we need to, when we're choosing an antibiotic in some infections, we need to have a thought about whether the antibiotic we're choosing has good tissue penetration for where the infection is. And this is a complicated slide, and I don't personally remember all this information. If I've got a serious infection in a child and they're very unwell, I usually go back to this sort of table and look at how good is the tissue penetration for a given antibiotic in a given infection. So if you've got a bone and joint infection, for example, then you want to know that the antibiotic you're choosing has good penetration of the bones and the joints, right? And so some antibiotics, such as vancomycin, we might think that's a very high-powered antibiotic, but you see it's got quite poor penetration into bones. So if you've got a child who's got MRSA infection of the bones, vancomycin is not the best drug to use if you've got other antibiotics that can be effective against MRSA. Similarly, if you've got a child who's got meningitis, then some of the antibiotics have quite poor penetration into the CSF. So that's why we don't use aminoglycosides. Gentamicin is not very effective against meningitis. Even though it might be good against the bacteria, it's not very effective because it doesn't get into the spinal fluid. Whereas other antibiotics like third-generation cephalosporins, they have high penetration of the CSF. And so that's why we use those antibiotics. So the reason why standard treatment antibiotics are chosen and is not just because they treat the bacteria, but also because for that infection, they get into those tissues, whether it's the brain or the lungs or the soft tissue or the urinary tract. As I said, I don't remember all this. I think it's important if you've got a severe infection that's beyond standard treatment antibiotics, then you should think to yourself, are the antibiotics we're choosing, do they get well into the tissues that where the infection is? I wanted to briefly mention how important it is to stick to standard treatment antibiotics. And as you know, we've tried to limit the use of third-generation cephalosporins, and that's because if you give too many third-generation cephalosporins, you just drive resistance. And I think all that resistance that I mentioned to you before, that when in Goroka 25 years ago, we hardly saw any, and then we started to see more. I think it paralleled the increasing use of third-generation cephalosporins. And this is a very good study which proves that when we limit the use of third-generation cephalosporins, then we get less resistant bacteria. I won't go through it, but it's in neonatal nurseries in the Netherlands, in Holland, a very good study done over several years. And it's where they used either penicillin and an aminoglycoside. So if you think about it, penicillin and gentamicin, or penicillin and tobramycin, standard antibiotics, or they used amoxicillin and a third-generation cephalosporin. And they found that when they used the third-generation cephalosporins, the cefotaxime, they got much more resistance. And so I would just encourage the use of standard treatment for most infections, and try to limit the use of cefotaxime, ceftriaxone, all the higher powered antibiotics like that, and preserve them for when we really need them. I think I've seen in recent years the increasing use of cefotaxime and ceftriaxone just for children with pneumonia, and that's quite poor practice. We should use third-generation cephalosporins if we're worried a child might have meningitis or the child's got severe dysentery with sepsis, but we shouldn't just use it for pneumonia or for diarrhea, for example. We need programs of infection control and antibiotic stewardship, so that everybody understands these concepts. And so it starts with some fundamental things. We should never give antibiotics for simple cold or cough, or for upper respiratory tract infections. We should never give antibiotics for those. And we should not give antibiotics for just watery diarrhea. And the reason I say those two infections is because they're two very common infections, and increasingly children are receiving antibiotics for those infections. And there's a lot of pressure to give antibiotics, I know. But if we just changed our practices so we didn't give antibiotics for those two infections, and we had other rules around antibiotics, then we'd have much less antibiotic resistance. All the things we've learned during COVID are very important for prevention of antibiotic resistance and for infection control. So good hand hygiene, using face masks can help. Isolation, gloves, gowns, they're very important if we've got a multi-resistant organism. I say here that enteral feeding of patients reduces the risk of antibiotic resistance. And the reasons for this are several. Firstly, if we're enterally feeding a patient with nasogastric milk, especially if it's expressed breast milk or even formula like F75 or F100, then you're protecting the lining of the bowel, and it's much less likely that bacteria will get across the bowel into the bloodstream. That's the first thing. The second thing is if we're using enteral feeding, we're using less intravenous fluids, so there's not the same risk of infection occurring from intravenous cannula. We should use shorter courses of antibiotics to reduce exposure, and we should have stopping rules. I never ever criticize one of my registrars for starting antibiotics. We should never do that, but we should stop if there's no evidence of a bacterial infection. And I think we need to be clear about what is evidence of a bacterial infection, and we should every day decide whether we should keep the antibiotics going or is it time to stop. So I think having stopping rules is really important. And I think it's good to have a weekly antibiotic stewardship round, and I'll mention what that is. There's a lot of different markers of infection, and some of them are not available in all hospitals. For example, in some of the more sophisticated markers like procalcitonin or CRP, they're not available. But we all measure the full blood count, but I don't think we make the most of it, right? We don't make the most of it. We should look at the full blood count in detail and decide whether there's evidence of a bacterial infection or not. And it's both the clinical picture and the rate of improvement of the child, like the rate of resolution of the fever, and what's on the full blood count that can tell us a lot about whether or not a bacterial infection is present. And so we all get used to the idea that if you've got a very high white cell count, we think that that might indicate a bacterial infection. But of course, you can have a high white cell count with a viral infection. And but sometimes there's a low white cell count, and that can be a sign of a bacterial infection. It's not so much the height of the white cell count, but the height of the neutrophil count. All right. So instead of looking, we can look at the white cell count, but then we should look at the neutrophil count. And if that's very high, then that puts the child at risk of a bacterial infection. Or if that's very low, like neutropenia or extreme neutrophilia, they're signs of a bacterial infection. Even more specific for a bacterial infection is if you look at the blood film or the printout from the full blood count and look for immature forms. So if you've got a bacterial infection, then the bone marrow is producing a lot of immature white cells all the time. They're called bands or myelocytes or metamyelocytes, and they're so often a large proportion of the neutrophils are immature neutrophils. They're bands or they're myelocytes or metamyelocytes or promyelocytes. And so when you see a lot of those, then you start to be concerned that it might be a bacterial infection. The platelet count can also tell us something. So if you've got extreme thrombocytosis, as in a very high platelet count, so more than 800,000, then that's a high risk of a bacterial infection. Similarly, if you've got a very low platelet count, that's a risk of a bacterial infection. There's something else on the full blood count called the red cell distribution width, the RDW, and that is often high when you've got a severe bacterial infection. And so I always look at that as well. And then some laboratories, when they've looked at the blood film, they'll tell you whether or not the neutrophils look toxic. And you can see these are toxic neutrophils. The neutrophils have a bilobed nucleus, but they also sometimes have lots of granuli in them. So you can look under a microscope and see whether or not there's what's called toxic granulation. And they're just these granules are just lysosomes that the neutrophils are producing to release enzymes and cytokines that might break down, that might kill bacteria. And so you can sometimes look at the blood film and see that this looks like a very toxic blood film, and that's highly suggestive of a bacterial infection. There are some other markers, laboratory markers, procalcitonin and ESR, but I'd just like us to make the most of the full blood count and start looking at that in more detail, along with the clinical picture and then the trajectory, like the rate of improvement of the child, in deciding whether or not we should keep going with antibiotics or whether it's okay to stop. If you see neutropenia with a high platelet count or toxic granulation on the neutrophils, then of course you're going to continue on for a full course of antibiotics. But if the blood film looks completely normal and it looks like a clinical picture of bronchiolitis and the child's not malnourished or have other risk factors, then it's probably safe to stop antibiotics because it's probably a viral infection if there's no high temperature, etc. So we can make these decisions after 2 days of antibiotics, and that can limit the duration of antibiotic therapy that children receive. And the last thing I want to say is that I think we should all have like a weekly antibiotic stewardship round. And so I think it's really good to every week just have a ward round that focuses just on children on antibiotics. And that can be just a sit down round. It doesn't have to be where you go around and see the patients, but you can review every patient who's on antibiotics, and you can ensure that in the charts there's a clear indication for those antibiotics written, and that there's a review date or a stop date. So I think it's important after 2 days of the antibiotics, we should always review the antibiotics and decide whether we should keep going or whether it's okay to stop. And if we want to keep going, we should decide on the duration. It could be 5 days or 7 days or 10 days, depending on the severity of the infection. And we should stick to that stopping date. We should check that in the antibiotic stewardship round, we can check the doses are appropriate, and that if the child's got kidney impairment, we can adjust the doses for their renal function. We should think about drug toxicity. So using, for example, several antibiotics at once can sometimes lead to cumulative toxicity. And we should review the microbiology, like the cultures and the inflammatory markers, the full blood count, and you can decide whether or not it's good to keep going or to stop. We can check that the antibiotics prescribed are consistent with the guidelines. So if people are using too much ceftriaxone for just moderate pneumonia, then that's a bad thing. You know, it's going to be bad for that child and also bad for the rest of the ward. And then we can make recommendations about those antibiotics. And so having just a forum, it may only take 1 hour a week, but having a weekly antibiotic stewardship round can be useful and focuses, and it can be educational as well. We can then teach about antibiotics and their use. All right. So that's all I wanted to say today. We've talked a lot about antibiotics and how they work, and resistance and how it develops, and different types of resistance and how we can avoid it. And I thought it was just useful to cover those things. So I'm going to stop talking now and see if there's any questions that you might have.
Thank you, Prophet. Thank you very much. I just want to ask one question concerning IV antibiotics in neonates. So we have an issue, especially in postnatal ward, where we have we get consults from ONG team to see usually neonatal sepsis patient with risk for neonatal sepsis, and comes with fever more than 38.5, very irritable, not breastfeeding well, we think it's neonatal sepsis. But then we started antibiotics, and just on the first day we started, clinically stable, no fever, and breastfeeding well. After 48 hours, it is clinically very, very stable. I'm asking how long should we continue with antibiotics? Is it okay for us to stop like in day 3, 5 antibiotics altogether and just send home?
Yeah, thanks, Glenson. That's a good question because it's a common situation, isn't it? I think the first thing to ask is when you have to make a diagnosis first, and I don't think that neonatal sepsis is a specific enough diagnosis. Sometimes it can be. The child's got a bacteremia, so you know it's generalized neonatal sepsis. But I think it's important to say, is the neonatal sepsis, is it cord sepsis, or is it pneumonia, or is it skin sepsis, or is it bacteremia, or is it meningitis? Because the duration of antibiotics is very different for different types of neonatal sepsis. And that they should be thought of as different neonatal infections for which different durations of antibiotics are appropriate. And some of them, and of course, some fevers in neonates don't even need antibiotics. So I think if the child's got very well in a short period of time, again, if the full blood examination looks okay, if there's no other risk factors such as very low birth weight or other risk factors, or the mother hasn't had severe chorioamnionitis, you know, if all the things look favorable, then yes, I think you can either stop the antibiotics or scale back. And sometimes the stopping rules don't relate to completely stopping, they'll be scaling back. And so you might have given antibiotics intravenously for 2 days, and then it's appropriate to scale back to amoxicillin for another 5 days, for example. And so I don't think you need to go for, 10 to 14 days with intravenous antibiotics in babies who do very well in the first 24 hours. And I would probably, in the child you're describing, then probably scale down to amoxicillin for a couple of days, observe the child, and then send the child home after a day or two of further observation, where they hadn't had a fever and where they remain well and feeding well, and then review them after 5 days. I think it's not as simple as keeping going or stopping. If you're going to stop or scale back, you have to put in place some review mechanism, but that's what we should do. So we limit the number, the time a child has to be in hospital, especially newborn babies, who we know if they stay in the nursery for a longer period of time on IV antibiotics, then they're at great risk of getting resistant organisms. And also they're at great risk of getting the other complications from antibiotics, which as I mentioned, changes in gut flora, often intolerance of feeds, and there's some evidence that if we give antibiotics for too long in newborn babies, they're more likely to get asthma later on. So there are a lot of complications of giving antibiotics. That's why we should reduce the duration of antibiotics where we can. Does that make sense, Glenson?
Yes. Thank you very much.
Good afternoon. Landy here from Tari.
Yes.
I just have a question.
Well, Michael, I'm having trouble hearing you. I'll turn off my.
We still, setting we're still 100%.
I'll turn my video off.
Can you hear me?
I'm having trouble, Michael. Try again. Ask the question again.
Well, I'm just asking about our setting here. We still